I think over the last 2-3 years, we've seen this flood of immuno-oncology agents available to us in clinical practice. And it's created, on the one hand, wonderful opportunities for patients. The flip side is it's really a pace of growth and change that's unlike anything I think we've ever seen in medicine before. That's been challenging for clinicians. What we focused on in our presentation today, most of these type drugs don't really require any kind of biomarker testing for their utilization, particularly when we talk about PD-L1 testing. Where we wanted to focus was, do we need to pursue utilization of that biomarker, even knowing that PD-L1 is severely limited as a tool? And so we established a few things. One, that PD-L1 expression is definitely important in frontline non-small cell lung cancer. We've seen that played out particularly with single agent therapy. The question is there a role for PD-L1 as a biomarker outside of that limited scope? And particularly, do we need to incorporate that into our clinical decision-making in other settings where we've kind of already been conditioned that there's really no role for that type of biomarker testing for use? So I focused on a few things, in particular looking at kind of going deeper into the data in non-small cell lung cancer in the second line that shows clearly with multiple drugs, whether it be atezolizumab, pembrolizumab, nivolumab, there is an obvious response curve when we apply these therapies so the higher your PD-L1 expression, those are clearly the patients that respond the most. The challenge in that, though, is that you do still see reasonable responses, although albeit in smaller numbers, in PD-L1 negative patients. That really is what creates this conflict. Most biomarkers we've used historically have either overwhelmingly predicted response, both positive and negative. The flip side may also be that it's been a biomarker like CD20 that's really stable in part of B-cell malignancies. So those are what we're exposed to. PD-L1 just doesn't behave by those same rules. It doesn't give us that kind of binary choice of yes or no, simple decision making. It actually kind of creates this uncomfortable new area that I think the temptation is to avoid this conflict between, how do I handle a treatment? A high expressor clearly predicts response, but we also still see responses in those PD-L1 negative patients. How do I handle that? It really is a tremendous source of conflict, especially when we look at trial design. How do we design the trial? Do we specifically look at PD-L1 expressors, high expressors, moderate expressors? Do we take all comers? The more patients we include in the study, that's positive from the perspective that we'll not have any potential responders untreated. The negative of that approach is our response rates are lower. The flip side is if we do use PD-L1 cutoffs, we'll see higher response rates with treatment, a very valuable, useful goal. The negative is there'll be patients that might have responded we don't treat. And so a lot of what we focused on our discussion is how do we reconcile this issue. So we looked at pembrolizumab, atezolizumab, nivolumab in non-small cell lung cancer. We looked at combination immunotherapy in melanoma, looked at head and neck cancer, bladder cancers, other sources where we do kind of see some enrichment with PD-L1 expression.